Well, my name is Ajar Kochar. I'm one of the interventional fellows at Duke, and I'll be presenting some of our work focused on the temporal trends and long-term outcomes of post-MI heart failure. Just to set the stage here, over half of contemporary myocardial infarction patients are aged 65 years or older. And despite the aging U.S. population over the past 2 decades, we've seen a steady decline in mortality. But on the other hand, myocardial infarction is commonly associated with heart failure. And there's some reports that suggest that this steady reduction in mortality may now coincide with a rising incidence in heart failure following myocardial infarction. And this would have significant long-term implications with respect to healthcare expenditure, quality of life, and morbidity for MI patients. The objective of our analysis was to describe the temporal trends and patterns of new heart failure following myocardial infarction in older MI patients. And second, to assess the association of post-MI heart failure with long-term mortality and major cardiovascular events. So we addressed this question, or these series of questions, in a 100% Medicare sample. We looked at the years 2000 to 2013. Our population included patients who were 65 years or older and had an index myocardial infarction event based on ICD-9 coding. We had 2 key exclusion criteria. One was death during the index hospitalization. The reason for this was we were interested in long-term outcomes. And second was we excluded patients who had a heart failure hospitalization in the preceding year to their initial event. And the reason for that was we were interested in new heart failure events. We defined post-MI heart failure by 1, either having a heart failure designation during the index event or being readmitted with a primary cause of heart failure anytime during the 1 year following the index MI event. The outcomes that we looked at were 1-year rates of hospitalization for heart failure and all-cause mortality at 1 year. And then our long-term time horizon was all-cause death and major adverse cardiovascular events. So to delve into our statistical approach, we did use the cumulative incidence function to estimate the incidence of post-MI heart failure. And the reason for that was to account for the competing risk of death. And then looking at our long-term time horizon at 5 years, we looked at mortality and major adverse cardiovascular events, comparing post-MI heart failure patients with patients without any post-MI heart failure, and used the Gray test again to account for competing risks. So these are our baseline characteristics, and there are really 3 salient points to take away from here. 1, our sample size was very large, greater than 1.5 million patients. 2, this cohort was very old. The median age was 78 years. And 3, patients with heart failure were relatively older and had relatively higher rates of comorbidities, including diabetes and renal insufficiency. To delve into the population a little bit more, about 2/3 of patients had NSTEMIs, a little over 1/3 had STEMI. And to really focus on our patients who had heart failure, about 33% of patients had heart failure during their initial MI event. 10% of patients were readmitted at some point within 1 year for a hospitalization that was primarily due to heart failure. And a total of 36%, so greater than 1 in 3 patients, had either heart failure during the index event or as a rehospitalization event within that 1 year. The median time to first heart failure hospitalization was 66 days. So in this graph here, what we're depicting on a month-to-month basis in that first year following the index event is what proportion of patients were admitted for heart failure. The black line represents patients who had heart failure during their index event. The red line reflects our overall cohort, and the blue line reflects patients who did not have heart failure during their index event. And the 2 key take-home messages for this particular slide is 1, the risk of hospitalization is highest amongst patients with heart failure during the index hospitalization. And 2, looking at the slope of all 3 of these curves, you see that there is a very steady increase over that 1-year period of the risk of hospitalization for heart failure. In our next slide, we show the overall temporal trends over the entire duration of our study, so 2001 to 2012, of 3 critically important endpoints. The black line represents the proportion of patients who had heart failure during their index event. The red line represents 1-year mortality. And the blue line represents the proportion of patients who were readmitted for heart failure within 1 year. And the critical take-home points here are there was a modest decline in the rates of mortality and heart failure that was statistically significant. However, despite this very modest decrease, the overall rates of mortality and heart failure continue to be very high, and in my opinion, soberingly high. Now, does heart failure matter? Well, the answer to that question, based on the data depicted in this slide, would be a resounding yes. Now, here we depict on the x-axis the years following discharge, and on the y-axis is the proportion of mortality. Patients depicted in the green line had no heart failure whatsoever, and their overall 5-year mortality rate was 38.4%. Now, that's high, but remember that the overall median age of this patient population was 78 years. Now, this is starkly contrasted with patients who had any form of heart failure. So the blue line represents patients who had heart failure during their index admission, but were not readmitted. And the red line depicts the opposite, patients who did not have heart failure during their index admission, but were readmitted with heart failure during that following 1 year. And you can see that their mortality rates were staggeringly higher, ranging from 66 to 68%. And patients who had both heart failure during their index admission and were readmitted during the follow-up 1 year had a 5-year mortality rate that reached 80%. So the key take-home message from this slide, really from this talk, is that heart failure as an endpoint really matters in the post-MI population. Compared to patients who had no heart failure, post-MI heart failure patients had significantly higher long-term mortality. So as a physician, what are the clinical implications of this Medicare analysis? Well, there is a large body of literature that describes that older patients are consistently less often treated with guideline-directed therapies, and that's both therapeutic from the pharmacological angle and revascularization strategies. So the very high mortality rates that we're depicting here and the high rates of heart failure, again, greater than 1 in 3 patients had heart failure, really emphasizes the importance of optimizing guideline-directed therapies, both pharmacologic and revascularization when appropriate. But moreover, it really underscores the need to explore novel treatment dimensions, such as active unloading, which may help with reducing myocardial demand. Secondly, post-myocardial heart failure patients have very high 5-year mortality rates. And from a patient-centric approach, I think it's important to share these data with patients and their family members to ensure that patients are better informed for shared decision-making. There are strengths and certainly some limitations of this analysis as well. The strength is that the overall cohort was very large, greater than 1.5 million patients. We had a long follow-up period that allowed for a national trend analysis. The limitations are that we used a Medicare analysis that does limit generalizability to patients who don't have Medicare. We used claims data that restricts our ability to understand the severity of myocardial infarction as well as the severity of heart failure. And finally, there are limited data that we had to describe appropriate therapy for either myocardial infarction or heart failure. So in conclusion, among older MI patients treated in the United States, the rate of mortality and heart failure has mildly declined over time. But despite this modest reduction, the overall rate of heart failure is very common, occurring in greater than 1 in 3 patients. And finally, compared with patients without heart failure, post-MI heart failure patients have substantially higher long-term MACE and mortality events. And with that, I'll take any questions.
Well, thank you for that. These numbers continue to be staggering and certainly relate to what we're talking about today and maybe perhaps impacting the incidence of heart failure post-myocardial infarction in the future with ventricular unloading and perhaps adjuvant therapies. So, Dan, you look like you have a question.
Yeah, thanks. That's really, really interesting data. And is it published already, or is it?
We're about to publish.
Okay, good, great. So earlier today, Jim Udelson referenced a meta-analysis that he and Greg Stone did about that related infarct size to subsequent heart failure events. And if I remember correctly, what they did was they segmented the population to the size of the infarct in terms of the percent of the myocardium that was involved. And it was only in that, like if there was greater than 35% of the myocardium involved, if I remember the data correctly, at 1 year, the incidence of a heart failure event, I think it was death or hospitalization, was only like 8% or so, which seemed very, very low to me. Your data are implying, I think, much, much higher rates. So I don't know if that's a function of the age that you're restricting it to older patients, or are you familiar with that paper and do you have any comments about it? And I have one other follow-up question.
Yeah, I don't know I don't remember the exact studies that were used in the meta-analysis, but I suspect so. So the other studies that have looked at national trend data and the overall rates of myocardial infarction-related heart failure, there's an analysis that was based in Norway, and they used data from all the way, I think, from 18 to much older. And they also showed much lower rates of heart failure for younger patients, but when they subset it on the older patients greater than 65, that's where really there was a much higher rate. And so in thinking about where to focus on, I think in this older population, heart failure seems to be much more common, and maybe an opportunity again to focus on areas for improvement.
And then just one short follow-up question is, I guess you don't have access to ejection fractions post, because I think even with small infarcts where EF may not be detectably reduced or very mildly, I think that it can contribute to this population of HFpEF.
Sure.
As infarct and and of course these patients have other comorbidities, but I do think that small infarcts can matter.
Yeah, I think that's a great point. So there are other ways to get at that question. So we at the DCRI actually linked the CRUSADE data with Medicare data. And so what that would allow is that you would be able to see, you would be able to have EF-related data and data from the index admission that's more granular, and then also have long-term outcomes. So certainly that's something that we could examine.
But one comment then, these are clinical trial data from the Stone analysis, which is, think about the patient population, vastly different from this.
Right.
Just a couple of questions. First of all, this flies in the face of our concept that reducing MI mortality increases heart failure prevalence. And the numbers on a population basis, they're not trivial reductions.
Right.
So is this more guideline-directed therapy? Do you have any sense of what's being instituted in the hospital that's accounting for this? Because this is a little bit of a flip on what we sort of conventionally think about with the growing population.
I think it's a great question. So we didn't answer that question with this data set just because we don't have it with the limitation of having Medicare data. The prior, we published with CRUSADE, the linked CRUSADE and Medicare analysis, and there we did look at recurrent MIs, and we looked at the rates of appropriate medical therapy. So specifically, that was from 2004 to 2006. What we looked at there was that the overall rate of prescribing evidence-based therapies at the time of discharge was actually very high. But when you looked 1 year out at what compliance rates were, the compliance rates dropped tremendously. So I don't know if we've done better, but I assume that overall we've just gotten better at taking care of MIs, and we've gotten better at prescribing secondary prevention medications. And so I believe that there is a reduction overall in both mortality and heart failure, but it's clearly not enough, right? The overall burden of disease continues to be really staggering, particularly in older patients. And like I mentioned earlier, over 50% of the patients that we're caring for who have myocardial infarction are now 65 years or older, and that proportion is only going to increase.
Did you differentiate STEMI from non-STEMI? Yeah. Are there any differences?
Yeah, good question. We did look at that. They're very mild. I'm happy to share those data. They're very mild.
Very interesting problem I can ask you. We know that the most important periods for dying in heart failure is those you have described over the years, but especially the first 30 days are important, this transition time.
Yeah.
So that means that there's still also a gap in treatment, which needs to be covered already in the hospital. So you have data about that, whether this is already a time to improve. And when we speak about impeller and unloading under these conditions, wouldn't it be extremely important to do already the best in the moment of the index, that the patient is already prepared for the transition period?
Yeah, I think overall that's a great comment, right? So to emphasize, right, 40% of the benefit of having an ACE inhibitor is if you prescribe it within the first day of an MI, right? The majority of benefit for eplerenone in post-MI heart failure is if it's prescribed in the first 7 days. So I couldn't agree with you more. The goal of this analysis really was sort of an overall trend analysis, and we don't have a lot of data about sort of how therapies were prescribed early on, but I couldn't agree more that I think as we look to bend the curve away from the sort of sobering numbers that we found, that focusing early on, focusing on transitions will be really important.
Thank you very much.
Absolutely, thank you.